Welcome, everyone. Thank you for joining us for our first module of the final Learning Collaborative of the SDOH Academy series this year. We're going to give folks about a minute to log in. It is right at the top of the hour here. Just wanted to let you guys know that, as I said, this is the final, hard to believe it, final Learning Collaborative in a 4-part Learning Collaborative series that the SDOH Academy has put together for health centers and community partners in 2020. And so we're really thrilled that you're taking the time out of what is a really incredibly busy and stressful time for all of you to be with us today. Next slide. So before we get down to the actual presentations, I want to just remind everyone, if you're new to GoToWebinar or if you have any technical difficulties, don't worry about missing any of the presentation. We'll have the recording and slides available to all of you, and you can always alert Danielle. So you see Danielle is the organizer for today. You can chat her or reach out to her with any questions that you have or technical difficulties. So as I said, this is this Learning Collaborative is part of our 2020 SDOH Academy series. So we, as members of the SDOH Academy, came together to create a series of learning collaboratives that we thought would really help health centers, primary care associations, health center controlled networks, and all their partners and community providers to come together and learn and dive deep into the social determinants of health. So if you have been on any of the previous learning collaboratives of this year, you know that each of these learning collaboratives consists of 2 90-minute sessions. So today we'll have about an hour of presentation, and then we'll follow that with 30 minutes of office hours. And we really encourage you to stay with us for the office hours because we have some additional discussion questions for you. And all of our speakers will stay on to answer your questions as well. If you haven't been with the SDOH Academy for trainings before, we consist of 16 national cooperative agreement associations, and we're supported by the Health Resources and Services Administration. Together, our 16 organizations really work collaboratively to create training and technical assistance that, again, explores the social determinants of health that we know each and every one of you is facing every day with your patients and families. Next slide, Danielle. So if you were on any of the previous learning collaboratives, we had our first that talked about humanizing enabling services data for patient care. Then that was followed by fostering a healthcare workforce able to address current emerging needs. Last month's learning collaborative was about reducing health disparities through community partnerships, and they did pivot that learning collaborative a little bit to discuss some of the issues that we've been seeing with the COVID-19. And today we're launching our Equitable Preparedness for Vulnerable Populations learning collaborative. And when we started planning for this, this was obviously before the COVID-19 pandemic hit us here in the United States. And so we've actually transitioned to really include a pretty specific presentation and discussion question style around COVID-19 so that we can provide you with resources and promising practices that you can really implement right away in your health centers and organizations. All of the learning collaboratives that the SDOH Academy has created were founded around these core competencies. And these are essentially the competencies that we at the Academy think are really important for anyone who is working with patients and families and wants to understand the social determinants of health. And they include improving access to quality healthcare and services, fostering a healthcare workforce able to address current emerging needs, enhancing population health and addressing health disparities through community partnership, and understanding emerging issues. And you'll see that all of the learning collaboratives we did this year really reflect those competencies. So at this point, I want to turn it over to Jillian Hopewell. She is my counterpart, my partner at Migrant Clinicians Network, and she's going to introduce some of the topics that we're going to dive into today.
Hi, everybody, and welcome. And as Emily said, I'm with the Migrant Clinicians Network. Emily is with the National Nurse-Led Care Consortium, and our 2 organizations are sponsoring today's webinar. And Emily and our organizations partner together quite frequently. The Migrant Clinicians Network is a national network that supports clinicians and other frontline providers who are working with migrants and other underserved populations, primarily people who are mobile for various reasons, and as well as people who are working in high-risk occupations. A lot of our work tends to be in more rural areas. And then the National Nurse-Led Care Consortium is based out of Philadelphia, and they have a focus on nurse-led care, as their name would indicate, but they also have a major initiative in public housing. And so we are an interesting partnership in that NNCC really brings a lot of expertise in urban issues, and MCM really brings a lot of expertise in rural issues, in addition to both of our clinical work and our focus on the underserved. For the presentation today, Emily and I are serving as moderators and will help guide this conversation, but our two experts who are speaking today are Reagan Carter from the Louisiana Primary Care Association and Amy Liebman, who works with me at the Migrant Clinicians Network. And we're going to have them introduce themselves when they are starting their presentations, and then they'll also be available during the office hours answering questions. Between the four of us, we'll field a lot of questions from all of you. So really looking forward to today. So as Emily said, today's webinar, it's best to think about today's webinar it's really a two-part piece, and our learning objectives really cover both of those, both of the sessions that we're going to be doing. So today we're really focusing on understanding the ways in which emergencies, and in particular COVID-19, disproportionately affect vulnerable populations, and we'll be diving more deeply into that issue. That'll be really the bulk of what we talk about today, but we're going to begin to identify strategies to adequately prepare for disasters and emergencies in a healthcare setting, looking particularly at responses that have happened as a result of COVID-19 and the role of health centers in that process. When we reconvene in a couple weeks, we're going to dive more deeply into strategies and then really look at interventions that assist patients, families, and communities during emergencies, both in preparation, recovery, and prevention. So we hope that you're able to participate with us during both sessions. They're really tied together and meant to follow one after the other. Just to let you know, there is going to be a brief session evaluation that will pop up, that will be launched after the sort of didactic portion of this webinar. But we hope that you all then will stay on for the office hours portion. At the same time, during office hours, it's meant to, although you do not have audio enabled, we want you to participate. We're going to be asking you a series of questions, want you to participate in the chat. But we also want you to put in questions and comments in chat throughout the entire webinar, and we'll be, where appropriate, we'll stop and answer some of those questions, but we'll really be looking at things that you say during the office hours portion. Okay, I want to turn it over to our first faculty member, is Reagan Carter from the Louisiana Primary Care Association. And Reagan, if you don't mind doing a brief introduction yourself, that would be fantastic.
Thank you. Good afternoon, everyone. Can you hear me?
Yep, we can hear you.
Yeah.
All right. Good afternoon. My name is Reagan Carter, and I am a public health policy consultant and advocate in Louisiana. I work across several issues, and of course, one of the issues that I'm passionate about is health disparities and social determinants of health. My work on health disparities and social determinants of health is with the Louisiana Primary Care Association, and I also am working with them on their RCORE substance abuse and opioid abuse planning grant. And so really excited to participate in this Social Determinants of Health Academy with you all today.
Are you there, Reagan? Oh, so if you want to go ahead and then start your presentation, that would be great.
We can begin the slide presentation.
Yes. So
just a little bit about the Louisiana. Okay, awesome. Can you hear me? Okay, just the Louisiana Primary Care Association was established in 1982 and promotes accessible, affordable, quality primary health care services for the uninsured and medically underserved populations in Louisiana. It is a membership organization of about 29 organizations that represent 250 health centers. Next slide. So what exactly is health disparities? I know that a lot of times in public health, we go from buzzword to buzzword. So what exactly do we mean by health disparities? Using the Kaiser Family Foundation definition, a health disparity refers to a higher burden of injury or illness or mortality experienced by one group relative to another. How I explain health disparities, simply stated, is an illness or injury that impacts some races and ethnicities, genders, and groups more than others. However, it's important to note that it does not mean that that illness or issue is exclusive to a group and that other groups cannot be impacted. In our work around health disparities, it's really important to remember that last note because we don't want to focus on the health disparities and lose sight that other groups are also impacted. Next slide. So what has happened with health disparities and COVID-19 in Louisiana? Louisiana has always ranked 49th or 50th as one of the least healthiest states in our nation. And so health disparities is not new to Louisiana, but COVID-19 highlighted health disparities in a way that they have not been highlighted before. Louisiana has a population over 4 million, so right at 4.6 million people. 61% of those of the population are white Americans, about 32% are Black African Americans, about 5% Hispanic, about 2% Asian, and less than 1% American Indian and Alaskan Natives. Next slide. Next slide. Thank you. So what did we find out about COVID-19 and health disparities? First, if you look to
Reagan, we appear to have lost your audio. I don't know if you can hear us.
the right of the slide, you'll see that the underlying conditions that played a major role in the deaths that we experienced from. Look at the about. Yeah, I can hear me.
I think maybe start over on this slide if you you cut out for a good portion of it.
Emily, let me know if you can hear me because I can hear you all.
Yeah, you can. This is Jillian, and we can hear you now, but I think you need to start over on this slide because it cut out for most of it.
Okay, awesome. So underlying conditions, if you look at to the right of the slide, you'll see that we have hypertension, diabetes, cardiac disease, obesity,
Hey Reagan, this is Emily.
Disease, asthma, and cancer. Those are some of the underlying conditions for people who die.
Hey Reagan, so it looks like we keep losing your audio. I wonder if we can get, if you're able to call in on your phone. It looks like that might be a better solution to keep your audio consistent.
Okay, let me disconnect and give me 2 seconds and I'll do that. I'm not sure what's happening. Give me just a second.
Sure. Sorry everyone for the technical difficulties. Never a dull moment with webinars, as you all know. But actually, while we're waiting for Reagan to connect her audio to the phone, I'd be curious. So we're seeing these underlying conditions here. I'd be curious if you all could share in the chat if you have seen some statistics similar to these in your communities, or whether you're able to get this information about your local community as a result of COVID-19. So feel free to share in the chat how these statistics are either reflective or maybe not reflective of what you're seeing.
To enable audio control, please enter your audio PIN followed by the pound or hash sign. If you do not have a PIN, just press pound or hash.
And Danielle, are you seeing anything come in on the chat?
Not at the moment.
Hey, this is Reagan. Can you guys hear me?
Yeah,
Yeah.
sounds a lot better.
Okay. Not sure what was happening there. I do apologize for the technical difficulties, but I hope we have it all squared away now. Going back to the slide about health disparities and COVID-19, looking at the underlying conditions, we have where hypertension, cardiac disease, cancer, diabetes, hypertension, obesity, and pulmonary were some of the major underlying conditions that we noticed from people who died from COVID-19. What we know, those same underlying conditions are conditions that we see in public health, where we have high rates of health disparities. In particular, when you look at hypertension, we know that hypertension, obesity, and cardiac disease is higher in minority populations. And so if you look to the left of the slide, you'll see that the reported deaths, and this is as from the Louisiana Department of Health from May 18th, you'll see that 55% of deaths from COVID-19 were Black, 42%, or right at 43%, were white. If you look at the ethnicity, 84% were non-Hispanic Latino, about 2% Hispanic Latino, and another 15% is unknown. If you look at gender, you'll see that there's not much disparity there with gender, 46% female and 55% male. So right at a 10% difference. But if you look at the race, huge disparities in terms of race. And if you look at the underlying conditions, we know that those are the same underlying conditions that we recognize have major health disparities in health and public health. Next slide. And so how do we connect health disparities and the social determinants of health? One of the major things that has come out with COVID-19 is that when we look at employment and we look who is exposed on a day-to-day basis, we know that there are more minority populations who are the frontline workers. When we think about grocery stores remaining open, we think about sanitary workers still having to maintain trash pickup. We think about hospital workers who are also in the hospital house cleaning department, hotel workers. We know that there is huge disparities among who is actually on the front lines having to maintain their job versus who is able to work from home. And so when we look at that employment data, you'll see that who is able to work from home, we have about 30% of white Americans have been able to work from home. About 37% of Asian Americans have been able to work from home. But then if you look at the Hispanic and the Black American population, only about 20% of Black Americans have been able to work from home, and only about 16% of Hispanic Americans have been able to work from home. And so what that tells us is that not only do we see the disparities within the medical conditions, but we see the disparities playing out very, very high when it comes to those social determinants of health when we're looking at employment. And so if you take a single Black woman who has to maintain her job at Walmart because she is the sole caregiver for her family, then she is on the front lines at work at Walmart every day and then going back home to her family. We also know that within the Black and Hispanic community, it is oftentimes where you have multiple families that live within one resident. And so an example would be if you take that same Black woman and she's working at Walmart and her and her mom are living in the same home, then we have someone that's already elderly, which is a high-risk population, being potentially exposed by a mom who needs her job and needs to be able to work. And so when we think about the health disparity and the social determinants of health, we think about all of those elements that have been highlighted and raised due to COVID-19. Next slide. So some of the policy implications for Louisiana, and some of these policy implications are certainly what we're seeing nationally, but specifically in Louisiana actually did Medicaid expansion 4 years ago. And every year during our legislative session, we have coalitions that are working to defend Medicaid because we have elected officials who are trying to say that Medicaid expansion is too costly. Medicaid expansion has not been successful. But what we know is that our minority populations are benefiting from Medicaid expansion through increased access, through early diagnosis, and through prevention. And so one of the policy implications is that if we maintain Medicaid expansion, then we're doing a greater job of being able to address the health disparities and the social determinants of health. The other two issues that are playing out right now in our Louisiana legislative session, because in Louisiana we're actually in session right now, is minimum wage and paid sick leave. Louisiana does not have a minimum wage higher than the federal minimum wage right now. And so we've had several legislators to propose raising minimum wage to $15. We have preemption in place, and so we've had several legislators who have raised the issue to allow local municipalities to be able to decide their own minimum wage. And unfortunately, for the past several years, those pieces of legislation have failed. And so when we compare that again to what's happening with COVID-19, we have placed families in our state in situations where not going to work is not an option for them because they're usually barely making ends meet as it is. And so that brings me to the paid sick leave issue. Here in our state, we do not have a mandate that requires employers to pay their employees for sick leave. And so this one is so extremely important when we're thinking about COVID-19 because we have the stay-at-home orders in place. We have the policies that say if you're feeling sick, you should stay at home, call your doctor, isolate, stay away from people. But if I am a minimum wage worker and I am supporting my family and I don't get paid for my sick leave, then I am forced to go to work and then potentially, unintentionally, exposing my coworkers and their families as well to COVID-19. And so when we think about social determinants of health and we think about health disparities, we have to think about all of the policy implications and all of the issues that play into us being able to look at those health disparities. In the blog that I wrote, I talked about how it's very important that we don't blame the victim because health disparities exist from years of bad policies that put minority population at greater risk for some issues than other issues. And so we have to begin to look at the policies and figure out ways to change the policies in a way that are more equitable across the board, across races, and across genders. Next slide. I didn't realize that was my last slide. Again, I apologize to everyone for the technical difficulties. Not sure what was happening with my computer. I appreciate the time to present to you all today. I will love an opportunity to present again, but I will be available for questions.
Great, thank you so much. There haven't been questions that have come in specifically. There was some questions about the employment data and whether or not that was national level data or Louisiana data. I believe it was for slide 18, which I believe may have been the stay at home. working from home. But
Yes,
maybe we
that
can.
that is national data that I obtained from a national article. I will pull it up and type it in the message.
Oh, perfect. Thank you.
Thank you.
Yeah, and then there's just people who have talked about seeing similar breakdowns in their location. And I think there will be more questions that will come in as we move forward and move into office hours as well. So thank you so much, Reagan, for that that overview. It was really great. And now we're going to move into a presentation by Amy Liebman. And Amy, if you don't mind doing a brief introduction of yourself, that'd be great.
Hi, thank you so much for having me take part in your webinar and office hours today. I'm really excited to be here. I am the Director of Environmental and Occupational Health for Migrant Clinicians Network, and I do a lot of work involving worker health and safety, and from research to policy to advocacy, looking at ways that we can improve the health and safety of workers who are often in high risk, low paid jobs. So what I want to talk about today is I really want to, I think Reagan gave me a great sort of point to start my presentation with. I want to look at work as a social determinant of health, and she really mentions two really important things, that the paid sick leave and the wage, that really fits into what we think about when we think about work. And then I want to take us up into thinking about this pandemic and what that has meant for work, and what we're seeing across the country in terms of workers in combination with other social determinants of health, and thinking about the messaging that's happening in terms of how we're thinking about our essential workers and what we can do to really address that. And then lastly, I want to get into some implications for health centers. Next slide, please. So I'd like to start off with just to introduce us to some folks that have been impacted by this virus disproportionately than other workers. And we're seeing just a tremendous amount of meatpacking workers just devastated by this virus. And I just thought I'd walk us through just a little bit of some personal stories here to kind of let us touch base with the whole idea of what's happening on the ground in the work. So this woman is a refugee and was a new grandmother, and she was the 8th employee at a Colorado meatpacking plant to die from COVID-19. Her name was Tin A, and she and her husband had wanted a better life for their young daughter and son. They wanted to get out of the refugee camp where their children were born in Thailand. And in 2007, they left Southeast Asia and arrived in Colorado. Tin did not speak any English and needed money to support her children, so she took a job at JBS's Greeley beef plant. And as the years progressed, she really didn't want to change jobs because she actually liked working around others who spoke the same language as she did. She still did not speak any English, and she also didn't drive, and her coworkers made it easy so that she could get to work. But she died as a result of her work on May 17th. And she found out she was COVID-19 positive because her daughter, who was pregnant, went into labor, and just as a precaution, the OBGYN did a COVID test on the daughter and found out that she was COVID positive. Now, the daughter went into, this is important, the daughter went into labor on April 28th. And when the daughter found out that she was COVID-19 positive, she called her mother right away and said, go to the hospital immediately, because she knew that her mom had been symptomatic for several weeks. In fact, earlier that month, okay, so this is like earlier in April, we started all sort of changing behaviors in March, but this is early in April. Tim went to the JBS's health clinic to be examined by the company officials. And she was told at that time that her symptoms were were, reflected the flu and the common cold, and that she could return to work. Next slide. So overall, this is probably this is last week, so the numbers have probably greatly increased since last week. But we have about over 10,000 meat packers and chicken processors that have been infected with COVID-19, and over 50 have died. Next slide, please. Another worker in South Dakota describes going to work and what it means to being an essential worker as being an essential worker just means you're on a death track. And this man from Liberia came to the US to build his dream, and he is COVID-19 positive as part of his job. Next slide, please. So I would like to just see if this can work, but I'm really I'm personally not impacted, but the community where I live in Salisbury, Maryland, there's 10 poultry processing plants within about a 50-mile radius of where I live. So my home community where I'm based has been greatly impacted. And the man in the picture here, his name is Miska Jean-Baptiste, and he worked for Purdue Farms right here in Salisbury, Maryland. And he died in April, and he was 44 years old with 3 kids. And his wife, Gilna Jean-Baptiste, we have a little video about a minute long that we're going to play that talks about Miska's last days and how he tried to get help, and how in some way, in essence, he was largely ignored or his symptoms were downplayed, and how he continued to work. So Jillian, if we're able to play that video now, great.
I went there and dropped him off, and I stayed in the parking lot waiting. They checked him the first time, second time, then they let him inside. They do that for 4 days. 4 days. And I said, if you keep on having a fever, I'm not going to let you go walk. I'm going to take you to the doctor. So I called, and they tell me to come. It was on Friday, and they don't let me go inside with him. So I don't know what's going on when he went inside. When he come out after like an hour, he said that the doctor said his fever was 105. So they give him 2 Tylenol while he was in the office because the fever was high. They give him a prescription. So I went to pick it up on Monday, and he started the medication. On Tuesday, that's when he can't breathe. If they would send him home, since they see him have the fever, I don't think I will losing my husband the way I lose my husband now. I'm lonely now.
Thanks, Jillian. So Miska, he's actually the cousin of a colleague of mine, and I think that his case represents, there's lots of things to unpack with the various cases that I've shared with you. We have a lot of low-paid immigrant workers who need to work, but also the challenges that they're facing even when they're not feeling well, in terms of some of the healthcare challenges, but and I'll get into some of the pay issues and sick leave policies in a minute. Let's go to the next slide. So I live in Salisbury, Maryland, which is right next to Sussex County, Delaware. So they kind of look at our whole area on the eastern shore of Maryland and lower Delaware and eastern shore of Virginia kind of as one one area, but the greater metropolitan Salisbury area, they call it, includes Sussex County. We're now number 12 on the list of New York Times hotspots, and we're actually decreasing a bit. But in Sussex County alone, we have 6 chicken processing plants. And I just wanted to break down the the rate of infection in terms of race and ethnicity. And it's alarming when we look at who are the essential workers in these processing plants. We have a rate of 742 per 10,000 Latinx individuals that are infected with COVID-19, 199 per 10,000 Black individuals that are infected, and 45 per 10,000 for white individuals. So the disparities there in terms of race and ethnicity are pretty striking. So essentially what we have in our meat packing plants is we have this toxic mix of a very dangerous work environment. Meat packing has long been a dangerous job. The industry is built on cheap labor to process our meat. Workers labor in damp, cold, cold conditions that are temperature controlled conditions, sorry, and often the plants are poorly ventilated. The line speeds, which have been dramatically increased over recent years, are forcing workers to work more closely together on that line. And also that speed of that line has limited workers from taking needed breaks. There's been reports of workers donning adult diapers to get them through shifts, which are both shocking and revealing of an industry that has long taken worker health seriously. And the job is also noted for its high rates of injury, where employees are commonly experiencing lacerations and repetitive stress ailments. Few of these workers have access to paid sick leave, although that does vary, but many cannot afford to miss work when ill, and they have a fear if they don't show up of losing their jobs. And it's been very, in my area, the fear of that the workers have expressed in terms of even when you're sick, not showing up and losing your job. Not so much even that they don't have paid sick leave. They're scared that if they don't show up, that they will lose their jobs. And the companies have said that they're changing their policies, but workers are still very confused about that, and it's not clear exactly how that's being translated to the floor and to the workers. So we have a really dangerous job built on this cheap labor. We have a vulnerable workforce, and so by the vulnerability of it, we're looking at some are immigrants, some don't speak the same language, some are older. So our workforce is made up of a number of different types of individuals that are vulnerable for various reasons. Education, race, immigration status, all those play into their vulnerabilities. And then it's an industry that really, the lack of regulations are striking. And if you go to the next slide, please, Julian, I'll talk a little bit more about those regulations. Essentially, these conditions, as I pointed out, are in the chicken plants and the meat packing plants. They're not new. We've known about them. And in terms of airborne infectious diseases, we've also been concerned about them in packing plants, and we've known about the ventilation problems because we've been concerned about chemical exposures. But just in terms of thinking about sort of pandemics and flu-like infections, after 2009, during the H1N1 epidemic, OSHA, the agency responsible for worker health and safety, enforced very clear and specific CDC guidance that was about protecting healthcare workers during the H1N1 epidemic. And then they started to write a standard that would look at protecting all workers in various industries from infectious disease. And that those regulations stopped or halted when Trump came in 2017. And now we have a Occupational Safety and Health Administration that is completely abdicating its responsibility to protect workers. There are new CDC guidances that have come out, but the OSHA is refusing to make them mandatory. And they're allowing plants to stay open without requiring any COVID-19 safety precautions. Now, some are saying that they're taking them, but there's nothing that is telling plants this is what you can and cannot do. And in essence, our federal government through OSHA has told workers that they can either risk infection and possibly death or not earn an income. And again, while some plants have taken steps like physical distancing or temperature checks, many of the workers, and I agree with them, believe it's been too little, too late. So what we're seeing with the COVID-19 pandemic is that it has fostered this massive worker safety crisis, and that's only been exacerbated by these lagging worker protections. And so, you know, in thinking about it, we really need to understand the nature of this essential workforce and the dangers that these workers put themselves in to ensure that our food systems continue. And so looking at stronger workplace protections, looking at increased hazard pay, or there's another word that I forgot right now that we like to use instead of hazard pay, but definitely paid sick leave and access to healthcare. And that's what we need to be thinking about for our workers that are doing this critical work. Next slide. So another thing that has been very concerning as we've watched just incredible numbers of folks who are working at these essential jobs, you know, helping to keep our food supply going, is the ease at which the political rhetoric has been blaming the workers, from CEOs of these companies to operation managers to high-ranking political officials, including the Secretary of Health and Human Services, really saying that, you know, the home life, it's the social conditions. Some are blaming the culture of the workers. And while it is true that poverty and crowded living arrangements are fostering community spread, we don't want to ignore that piece of it. It is really important to recognize that it's a faulty and downright dangerous response to downplay the workplace and what that means for this pandemic. And when we look at the workplace with this pandemic, we're seeing at least 170 plants in 29 states that have had one or more workers test positive for COVID-19. And the outbreaks have prompted at least 40 processing facilities to temporarily close since the start of the pandemic. Now, some of them are back open. And these are these are the hotspots that have popped up all across, you know, rural America. And again, when we think about the workplace, I want to stress too that it's not limited to our country, that Canada, Germany, and Ireland, they've all reported hotspots that are associated with meat facilities, meat processing facilities. And just today, I was looking at a report from Brazos County, Texas. They have 176 active cases, and 62 cases are tied to the poultry plant there. So it's super important and really important for us to think about sort of the messaging around this, that yes, we do want to acknowledge, you know, in some cases, crowded living conditions, you know, particularly when we're thinking about farm workers, for instance, but understanding that this infection is, workers are getting infected at the workplace and bringing it home. So we need to be looking at the conditions in the plants if we want to impact how this is spreading in our communities. Next slide, please.
You know, Amy, before, I think the next one is moving on to health centers. And before we go there, there's a question that I think is important about childcare and talking about essential workers who are often from minority populations and often have children. And so what happens around childcare?
So childcare is challenging. So I'm not quite sure the question. So a couple things. One is what we are seeing in my community, and there's going to be some national data coming out on this as we move forward in the next couple of weeks, but I don't have a source for you right now. But we are seeing as workers get sick, it's spreading to their families, and we are seeing children of these essential workers getting sick. In terms of childcare, workers are really suffering in that they need to have a place for their kids to be when they are working. And so much of the childcare has fallen to relatives and friends. In some cases, we do have childcare centers that have been allowed to be open for some essential workers, but in many cases, like Migrant Head Start has had to shut down in terms of childcare provision. So it has highlighted the crisis that we have in our country around childcare as well, and it's a really important thing to look at when we're thinking about these essential workers.
And there's also a question that I'm not sure we can really effectively answer at this point, but the question is, how many deaths are the result of inadequate medical care where patients are misdiagnosed or not treated properly for their symptoms? And I think that is a question that kind of remains to be seen. We're so relatively early in this right. pandemic, but Amy, do you have any other thoughts on that?
Yeah, I do. I think it's a great question, and one of the points that I really hope that you walk away from my presentation today with is that on the healthcare side, recognizing and understanding the work that our patients are involved in is critical to their care. So at our local hospital now, and this is the first I've been at this work for over 20 years, and they're actually asking people, are you associated with the poultry processing plants? And that is a huge step forward because that should send, raise the awareness of clinicians that, wow, this person may be potentially exposed, or this person is working in these conditions, and I need to think about the work that this person is doing as I do my diagnosis. So if I have the luxury of working at home, I'm giving this presentation to you from my living room. If I was to talk to my clinician about where I work, maybe like prior to COVID-19, she might want to think about sort of my travel or that I sit all day long or whatever, but really understanding what it means to be a farm worker, and what your exposures are there, what it means to be a meat packer, and what your risks are. So I think that we don't know what's happening in terms of, folks who are ill and who are being turned away. But it's a really important question, and we do know that we haven't been thinking about the work as we were making these diagnoses and as we're thinking about it. So, hopefully today, if a worker like Miska walked into the clinician's office, they would not have sent him home, and they would not have let him wait till Monday for his poor wife to pick up the prescription. They would have been perhaps much more concerned right away. I don't know, hopefully that's changing, but the point is that thinking about work is going to be critical as we move forward, and as our country begins to reopen, understanding these exposures is going to be really critical to their care.
Okay, and one more question before we move on to that.
Okay.
It's sort of a two-part question. Are any labor unions in these settings responding to these issues, and are there educational efforts being done with workers?
Yeah, so this is our moment in worker health and safety. We have epidemic of worker safety going on, and essentially in our country, as we've progressed, our labor unions have been weakened, but most of these jobs that I'm talking about in the poultry plants and the beef packing plants used to be strong union jobs that allowed people to afford a middle-class life and send their kids to college. And that changed a lot starting in the 1980s. And now your ability to sort of earn a middle-class living working in these plants is impossible. There are a lot of unions that are involved with the workers, but union participation overall in our country is down. There's also a lot of really interesting worker centers. They're largely in cities, but there's a lot of different groups that have responded in ways that are sort of outside the traditional union that are trying to help workers. And then in communities, there's just a lot of different community groups that are working really hard to help with the education of the workers. But it's really mixed, and it's not systematic. And I think if we had stronger groups if we had a stronger union presence, I think in this case, we might have different scenarios. Okay, so the implications for health centers and clinicians, I think, is really they're strong, and clinicians do have an incredibly important role at the health center level. First off, just in health centers can play a really important role in screening. They're trusted sources, and they may understand better the type of work that their populations are doing. And I think the importance too that as clinicians, as advocates, and clinicians are just can be a really strong voice in standing up for the workers. It's been a really scary and interesting time for Migrant Clinicians Network because we work with so many clinicians, and usually our partnership with our clinicians are about improving healthcare and healthcare access and quality of care for our immigrant and migrant workers. And both in this pandemic, both our healthcare providers, our clinicians, and our workers are both incredibly vulnerable. But clinicians at community health centers can play a really important role in terms of the screening, in terms of the education that's offered, and in terms of being an advocate. Our second webinar in this series is going to delve a lot more into community-based strategies that look at mitigating some of these issues. But I'd like to just give us a couple examples of what health centers are doing across the country. Next slide. So this is Dr. Elva Galvez. She's one of MCN's board members, and we're super proud of her because in essence, she's doing everything that I just talked about in terms of what the clinicians can do. First of all, she has been just an incredible advocate in Oregon, where she is based. She has been a part of the process that helped get emergency orders issued for farm workers in Oregon. And then also, this whole pandemic, she has just stepped up and been a real leader in terms of what can the health center do. So she has been getting out to labor camps, doing testing, mobile testing on site, and has been really trying to work with growers and workers to figure out the scenario of, what will happen if they test positive and getting results to workers. So that just being an advocate, but also being out there screening and then working with employers, working with the families to help them address this is just a really important role. And then I'll finish up with our last example, and this is in Wisconsin. Wisconsin offers just a really great model in that the governor there issued executive orders specifically around farm workers. And so there's been a coalition that has been led by the Family Health La Clinica in Wisconsin, and they were instrumental in working with the governor to get those regs passed. And then they have a whole risk mitigation strategy where they're getting out there as workers arrive in Wisconsin. They're testing them. They're helping to set up protocols with the growers to make sure that anyone who's testing positive, there's a place for them to isolate. And it's been really amazing to watch that. And I think, ending on a little bit of a hopeful note, because we do need to have hope in this pandemic, is that it is feasible to have people go back to work and to work safely when we put the right measures in place. When we have risk mitigation, when we're doing the testing, when we're doing the contact tracing. And I think that, what's happening in Wisconsin, I think it's really important to underscore that there's a regulation that backs up what the Wisconsin Farm Worker Coalition is trying to do, that hopefully is helping make growers more responsive. And then they're out there actually implementing these processes with the testing, and hopefully we will see fewer agricultural workers in Wisconsin suffer as a result, and they hopefully can serve as a model showing that our economy and public health are not mutually exclusive, that they can go hand in hand when we're taking the right steps. So that's the end of my presentation. I don't know if there's any more questions for me.
There was a comment, there's a couple of questions, but a comment about that COVID-19 coincided with the implementation of the public charge rule, which may make workers more vulnerable.
Absolutely. I don't know what to say to that, except you're right.
Yeah. And then there's a question about the role of community health workers, and our community health workers being used for outreach efforts to communities for workers' families.
So I think that there's some really mixed models taking place, and I'm curious if any of you on the line have some models to share. But in some cases, community health workers are being used. I know the initial sort of utilization of their services has been more sort of a phone-based outreach, but they're really important players in this. And usually our approach is that our community health workers are out in the community and they're talking directly, and that's been challenging in this pandemic. But there are examples of community health workers going to the local radio stations and calling folks and doing different types of things to try to reach the population that they serve. And I think as we move forward and as we reopen, I think they're a really important component of the healthcare team that can help us address this pandemic, because education and contact tracing is going to be a huge part of how we move forward.
Thanks, Amy. Jillian, I'm wondering, this is Emily, I'm wondering, since we are close to the top of the hour, if we can roll right into office hours and really still and use that time to address additional questions that we have that are coming in, because I think we're having a great discussion about not only Amy's presentation, but really just, I just saw in the chat some of the disparities that folks were seeing earlier that kind of resonated with what Reagan had presented. So I'd love to hear more about that in the office hours as we roll into that. But first, we would really appreciate all of you to complete a survey that's going to be launched, I believe, right through the platform or in the chat, and Danielle can confirm that. But we'd like you to just evaluate the didactic portion of today's presentation before we really move into the final 30 minutes of the module, which is really dedicated to exploring this topic further with all of you and with our speakers as well. So Danielle, is that survey going to be launched via the chat?
It's actually going to be launched at the very end of the webinar and also through the follow-up email. So
okay.
When we conclude the webinar, it'll be launched automatically.
Okay, great. Thank you. In that case, Jillian, I think we're going to kick off our office hours.
Yep, here we go.
Great.
So the idea, oh yeah, and we can show our...
Yeah, some of us are going to show our webcams to give you a little break from just looking at slides. And I know not all of us are able to do that, but for those of us who are, we're going to share our webcams with you. So I think we had another question. Did we have another question that came in about the slide presentations? We answered all of them.
No, there are no more questions about the slide presentation. But the idea with the office hours is we wanted to ask you guys some questions and give you the opportunity to ask some questions and to put those into the chat box, and then we'll make that part of the overall discussion. So some of the questions that we started with, this first one is, have you seen social determinants of health impacting patients in your region during the current pandemic?
Yeah, we had some folks already type in that when we asked them in the chat. Actually, Reagan, if you're still on, it was a good, helpful technology issue because we were able to get some great chat information about what folks are seeing in terms of some of the disparities. I would love for folks to unmute. I think you have the ability to enable your audio, or do they not? Jillian?
I don't think audience members do have.
Oh, okay, never mind. If you can share in the chat or extrapolate on what you had shared earlier about some of those disparities that you're seeing as a result of COVID-19.
And this is Reagan. Yes, I'm still on.
Great, glad to have you, Reagan.
Thank you.
Also, as you're typing your answers to this question, I wanted to alert you to the resource that we shared. It's just a fellow National Cooperative Agreement, MHP Salute. They do a lot of work with community health workers and optimizing community health workers. And I just wanted to put that resource out there as another way for you to get information about community health workers and how they're being utilized during the pandemic. Okay, great. So we're getting some answers here, including employment, childcare, school, access to food, etc. So that's another question, and I wonder, Reagan and Amy, if you wanted to speak to this as well. You're thinking about how migrants or agricultural workers or other folks in underserved communities, their kids, not only do they need childcare normally, but now their children may not be in school, right, during the day. So how is that, we have to think about how that's even impacting some of those essential workers as well. Knowing that, I know here in Philadelphia, for example, and I'm not sure how it has shaped out across the country, but in Philadelphia, the city Department of Education didn't begin online classes until the first week of May, because they had to comply with free and equitable education for all. So because they weren't able to get laptops and internet access to all the kids, they couldn't start online classes. So the kids had nothing for a month. And so that, just thinking about that is really, kind of startling and staggering to think about.
There's some other ones about access to food is running throughout as an issue.
Yes, in Louisiana, that's definitely what I was going to comment on. Access to food in terms of our children being in school. We have high rates of free and reduced lunch in Louisiana. And so what that translates to is if kids are not in school, having major concerns about them having access to food. Our school systems started off making sure that they were providing food on a daily basis. But with that became the parents had to be responsible for picking up the food. And so that also brought about transportation issues, because we know that with high rates of free and reduced lunch, we also have high rates of kids dependent upon school buses as their transportation to school. And so how were they going to access the lunch? And so we had lots of policy issues that needed to be worked out around students having access to lunch. We also had several incidences where there were COVID-19 cases that were diagnosed among some of the school lunch workers. And so I know of 2 school systems who temporarily shut down their school lunch programs because of multiple employees who were diagnosed with COVID-19, in a way to protect the other employees as well as protect the students and families who were picking up the food. And so then that created access issues for a couple of weeks for those students as well. So definitely food access issues and access to school lunches.
Really great point.
We're also seeing issues with housing.
Yeah.
In particular, there's a lot of things coming in, so thanks everybody. But
Actually, speaking of that, Danielle, are we able to save this chat and like have it? I wonder if we can type up some of the things that we've been seeing, because this is so interesting.
Yes, the questions can be saved. Yeah.
Okay, great. Sorry, Jillian, go ahead.
Oh, this has been something that I've been really concerned about, is evictions for past due rent.
Yeah.
People are unable to work.
Yeah, so that's actually a really, and we didn't talk a lot about housing. There's so many things, you know, as you all know, the social determinants of health are interconnected and intersectional, but, you know, there's so many issues that we could dive into. Housing is really critical. We in Philadelphia, there has been, and Pennsylvania is a moratorium on evictions up until, I believe, June. So it's illegal then to process an eviction against someone until I think a certain date in June. But then after that, we're really expecting some serious issues to come up, because folks just aren't able to pay rent at this time. And I know HUD has put a moratorium on evictions, I think, until further notice, but that really isn't a long-term solution for what we're going to be seeing. I don't know, Jillian, if you want to share some more about that.
Sorry, no, I'd just be curious to know what is happening around the country for that issue, because I just think it's going to be, through the summer, this is going to be a major.
Yeah, absolutely.
I'm curious, someone put in there about the current SNAP policy, disenrolling large number of hot lunch children. I'd be curious to know what state you're in and why. What is it about the current SNAP policy that it seems like disenrolling children at this moment in time?
So, yeah. Jillian, as folks are responding, I think one thing that Reagan made really clear in her presentation, I don't know if I said it as strongly as Reagan did, but as we deal with this, you know, public health crisis and, you know, a disease, an infectious disease, we are seeing all these other pieces, you know, housing, food access, work, paid sick leave, you know, health insurance. All these things are impacting us as a country in being able to respond adequately. And so I'm hoping, again, being hopeful, our silver lining as we look at that is for us to no longer disconnect that, you know, paid sick leave is a public health issue. Health insurance, access to health care is a public health issue. Food security, all these things, childcare, they all sort of are going to impact the health of our community. And we, as a country, we don't necessarily look at those kinds of policies necessarily as health related policies, but they are. And I think that this pandemic has made that super clear. And again, sort of going back to sort of what is our role at community health centers? What is our role as clinicians? More so than ever, the need to advocate for these really important policies that are going to impact our health. And I think if we look around the world and we see countries where access to healthcare, access to paid sick leave, access to childcare, all those things sort of like are kind of non-issues because they're already part of the systems. They're doing a much better job at being able to respond to this. And we have just ripped this like thin little curtain off of a really vulnerable system, and we're seeing failures on so many ends that are, and now it's impacting every single one of us. It impacts whether our kids can go back to school in the fall. It impacts whether we can go on vacation. I mean, not that those are kind of minor things for us when people are trying to survive, but it impacts every single one of us on this call, regardless of our status.
Absolutely. There's a question in here about strategies for advocating for broadband access and internet access, and that kind of brings us to one of our other questions. I know we could talk about this question for half an hour, but I wonder if some of you are, I forget what the next question is. Is it the one with promising practices?
No.
But this would be good too, though.
Which one do you want to do?
Well, I have a question about what folks are doing in their communities, and to your point, Amy, about advocacy. Yeah, I think this is a good question to kind of go from that, because if we're talking about, okay, we can advocate for these policies on a really national, wide, broad level, but then what are you doing on the ground? You know what I mean, to kind of advocate for that or make a change in some way. And I think the advocating for internet, like talking to an internet provider, for example, and trying to get access for your patients is an example of that. So I would love to.
There's a question that was a little earlier that I don't want to lose track of, but the person asked, what are the important next steps we can take to help our populations most impacted by social determinants?
Right. And
do we have an action plan in place of what to do if deaths increase in this population?
I mean, that's the question, I think, and hopefully that's a question. I think this is really good information for Jillian and I and our faculty, because that's a question we're going to want to maybe not answer, but really address in the next module, because that is the question is, all right, well, we're here now. Initially we were going to do this learning collaborative about preparedness, but we really are here now. And what can we do at this very moment? So I think that's a great thought for us. Oh, this is great. From Lebanon, New Hampshire. We're offering cell phones and data cards for those without internet access. This is at the, I'm assuming, a health department or maybe a health center system. I wonder if that person could share where they're getting funds or resources to do that, because that's a great suggestion.
I also saw that someone in New Hampshire and Vermont, the school buses are delivering food to kids.
Absolutely. One thing I know that in Philadelphia,
question, we're not going to see results right away, but I do know that in the stimulus package, I don't know, I'm not an expert on that part of the policy there, but I do know that there was some emphasis placed on improving internet access. But I don't think, I think it's just we're not going to be able to see it fast enough in order to make an impact.
Yeah, I think the other question, or one of the things I was going to mention about not necessarily internet access, one thing that has happened in Philadelphia, and I would be curious, Dartmouth Hillcock Medical Center, that's wonderful. Many internet companies in the Philadelphia area are offering like unprecedented low rate, $10 a month for families. I don't think that's universal. I mean, certainly that's Comcast is doing that here. One of the things that they've been doing around housing in Philadelphia here is, I don't know how many health centers on the phone have integrated medical legal partnerships, but having some kind of legal resource available to your patients who are experiencing housing issues or housing instability, unable to pay rent, having a pro bono, public health law experience or expertise rather at their disposal or at your health center's disposal might be really, really valuable. And I don't know, Jillian, maybe we can share at the S2H Academy website, you can find information about the National Center for Medical Legal Partnership, which I think could provide some resources around that. That might be a really great way to create a partnership and have that help some of your patients at this time.
Yeah, and there is someone who commented on legal assistant, that some legal assistance offices are closed during this time, and so people don't have access to the legal representation that they may need or the advice that they may need for things like foreclosures.
Right. Yeah, I mean, I know obviously being based here in Philly, I know some of the resources here, but I would love, and actually I'm going to add this.
There's another one too here. Did you see in Reading, Pennsylvania?
Oh, hey, Reading. Yeah.
Working with a community group and a magisterial district judge to work on a plan to help provide representation for eviction hearings.
That's great. How did you, I wish that we could hear, but how would you begin that partnership? Because I think that would be something that other health centers would be really interested in.
Yeah.
That's great.
So it looks like the funding for the cell phones and the phone cards came from a United Way grant.
Great.
I know in our community here in California, the community foundations have been a great source of funding for that sort of direct assistance to patients. It's, again, that gets us to it is scattershot, and it's depending on the resources that are available in your community. But, oh my goodness.
I'm so excited about the wealth of information we're getting in this chat. I mean, this is just really like amazing, promising practices that we're hearing. Great. Okay, so it sounds like the Reading Hospital Medical Legal Partnership is working with Barrio Alegria, I guess, in Reading on landlord-tenant issues. So yeah, I think that Medical Legal Partnership is a great example. And I think legal partnerships can work on work-related issues as well. I don't think it's exclusive to housing.
Absolutely, absolutely, they can work on work-related issues.
Yeah.
Great.
So another question that I had, there were several questions about community health workers. And I will say that we hear from a lot of sites across the country that they either furloughed or laid off their outreach and enabling staff. And I'm curious if that has happened at your site, or if it hasn't. I guess the really more important question here is who has been able to maintain their outreach and enabling staff, and how were you able to do that?
Yeah, that's a great question.
And we're still getting responses in from the previous question, so we have a a lag in our.
I'm just really excited. I think this is a great charge for us to maybe try to pull some of this together. I know we have a lot to do for next time, but I would love to pull some of this together and really like share this report out with all of you.
Well, and as a bit of a sort of a kind of an intro to thinking about the next session, we'll be looking at different types of responses, but one of the things that we're going to focus on is looking at the community resiliency and the resources within a community to prepare for disaster, with the idea that then those communities are more resilient and that really kind of build on the strength that exists within communities, which a lot of you are showing. There are all the challenges that you face, but looks like there's just also tons of solutions that have been developed.
Great, yeah.
So in Florida, a lot of layoffs of, what does ES stand for? No.
I think enabling services potentially, probably.
Yeah, thank you. Yes, repurposing for contact tracing is something that has been done in some sites. I know Massachusetts was one. And some of it's just an issue of figuring out the legal ramifications as far as, are they covered under FDCA for the health center? So there's some issues there, but I think there's a lot of room for creativity.
Mm-hmm. Yeah, I want to raise a good point here, and this point's well taken, is that, providing phones and making purchases on behalf of patients for health centers may be that may be restricted or problematic under the grant or some of your restrictions that you have at your health center and under HRSA. But I think now is the time for, it sounds like that Department of Health or hospital systems, now is the time to really think about, all right, well, can we get, a hospital system or a university or somebody to kind of help us sponsor a program that would, raise funds to get phones out to folks? If we can't do it, can we get a partner to really, go to the next step, even though they're all trying to serve their clients and patients as well. But in a lot of situations, I think you would share, especially for those hospital systems, you share that population as well. So great.
So folks working from home too. Okay. So it sounds like in the case of the site where you have screeners and navigators working from home, and those are the staff that can really address SDOH issues. It sounds like you've been able to keep them on staff.
That's great. So here's a great question. Yeah. One of the things that we talk about in a lot of our SDOH Academy work is screening, which we know many of you probably use Prepare, or you use, an amalgamation of Prepare questions and other questions from different screeners. But really just want to get a sense from you guys about whether you do screen your patients for what they do to work. So similar to what Amy was saying is, are you aware of kind of the conditions that may be present for your patients in their sort of work? And I think this is my personal kind of thought, but we don't often, I think, talk about work and employment as much as in social determinants of health as we may talk about, access to food, housing, and other issues, which are all obviously very important. But I think the work piece is, especially now, more important than ever, it seems. Okay, not that we're aware of. Okay. Yeah.
So
okay.
as they get into high prevalence area. Okay.
Yeah, it might be worth examining your Prepare or your SDOH screening tool. I mean, I know it's hard to say, okay, what's your occupation? I mean, that's not sometimes really illuminating, but I wonder if there's an option. And Amy, do you have a suggestion about how they could ask that question?
Sure. So we actually have a tool that we developed at MCN, recognizing that the real estate is so tight on any kind of intake, but it's really asking them about the work they do as opposed to sort of your occupation. And I think, Jillian, maybe we could share that with folks. And we have designed various versions of it so it fits in well with electronic medical records. And we were really thinking about it largely for farm workers, but folks that are working in high risk occupations. And so it would fit really well with this particular issue. And just regardless of, so as we move forward, like understanding if someone, like Reagan was talking about, if someone works in Walmart, understanding if someone is, as a grocery store, checkout person, all those things where they're going to come in contact are really important. So I think our tool would be able to get at some of that. And then the next step is, okay, so what does it mean? And in this case, thinking about occupations that are either where understanding what the conditions are in various factories, like I described the chicken plants. I mean, understanding that they're cold, damp environments that are ripe for this virus, that there's poor ventilation, that workers are close together. Those kinds of things are really important to understand. And then, you know, just in terms of retail or farm work, like there's a number of different things to think about given what your patient does and how their health might be impacted.
And typically the way that what we suggest is that we ask them to describe what they do for work, so that it's not, because someone may be doing construction work this month, but they don't see themselves as a, you know, a carpenter or a contractor or whatever, you know. So what do you do for work is the way that we, and I sent the link to you, Danielle, sent it to you, Emily, by mistake initially. But
yeah, I saw that, but I was like, oh, yeah, I think this would be great if, you know, we shared a couple links, you know, and I think if we can pull those together for you, that would be, that'd be really helpful. But again, I mean, we know that you're screening your patients for SDOH maybe on an annual basis, maybe, you know, it just depends on what's going on, especially now it's really difficult to roll out these screeners. So it may be that you do like a piloted rollout with folks that, you know, a certain segment of your population that are high risk or are otherwise coming in with, you know, symptoms that you might want to say, all right, let's roll out this particular screener and see how this is implemented and operationalized in the center before we really go with the whole population, because that's a challenge as well. So
so Emily, we just have 5 minutes left. Do you want to talk about the follow-up piece that we have for people in preparation for the next session?
Yeah, absolutely. So Danielle is going to share with you guys in the chat a survey monkey. This is an anonymous survey monkey for you, and really it's more for you all and your edification, but it's a preparedness, or it's a pandemic assessment rather. And it just kind of is asking you to reflect on your own experience at your organization and what you're seeing in your community in terms of the SDOH implications and how SDOH has been exacerbated by this pandemic, and some of the really top concerns that you have about reopening or just the next couple months, what that looks like. So we're asking you to complete that survey as sort of a homework assignment. It's also going to help us, again, really prepare for next time and bring those resources that we think are going to be really critical for all of you. So Danielle just shared that in the chat. So we really encourage you to take that survey. And then we have on the second page of it, if you want to receive a copy of those results, we'll email that to you. And maybe that's something you could, you know, share with others in your organization, or, you know, if that might be helpful. And then we also have an option on there if you want to share on the next module. We want to hear from you all and see if you want to share some thoughts and promising practices. So let us know on that survey if you would like to do that. That would be excellent.
Are there any final questions? We really appreciate all of you that have contributed so much to the online conversation here. There was one of the last comments was about an approach in Chicago, the pop-up shop approach to get donated face masks. Yeah, a better way to, yeah. I mean, it's interesting, you know. I think, I mean, a little editorializing on my part, but in the absence of sort of a coherent national strategy, there's been a lot of this kind of pop-up community-based solutions, which it's like, it's, you know, it's a double-sided thing, right? Like the community-based pop-up solutions are fantastic. And certainly we want to encourage that sort of local activism. But it would be great, you're right, whoever made this comment, that to have a better way, a more consistent way, or perhaps something that people could feed into, so that the local activism really had an overarching structure to tie into.
And Jillian, that's a great lead in to, I think, what's going to take place at your next Learning Collaborative webinar, in terms of some of the community mobilization strategies that Maricel Pagan Santana is going to talk about. And essentially, you know, Maricel's going to be talking about, we'll plug the next one, what happened in Puerto Rico after Hurricane Maria. And essentially, you know, they were abandoned by government, and community health centers played an incredibly important role in that case. And this project that Maricel's heading up in Puerto Rico really looks at building on that leadership and the strength of communities and how to address, you know, we're using it and how to address emergencies, but I think it can be used in a number of different ways. But I think that's a great lead in, and I think we're seeing it across the country that we're turning to our local resources because we're lacking a cohesive plan and approach to this, to say the least.
So on that note, we appreciate all of you, and we hope to see all of you back with us in a couple weeks for the follow-up one. Thank you so much.
Thank you, everyone, and thank you to our speakers, Amy and Reagan. Thank you so much for being with us and sharing your expertise with us. Really appreciate it.
Yes, definitely.
All right, have a good rest of your day, everyone.